Hello, good evening, everybody. Can everybody hear me? Hello, good evening, everybody. Hi, Dr. Value.
Hi, Ms.
You're
Sia.
already on the screen, Dr. Value. Right.
Yeah.
So, Dr. Value, before we start, I just do a quick introduction. So, good evening to everyone. Welcome back to our Facebook Live. And again, I'm going to introduce myself. My name is Xiao. I'm the pharmacist from NSCMH Medical Center. And here we have Dr. Value. Our topic today is small hole, but big problem. Later, Dr. Value is going to tell you where or what are the small holes later. So before we start, again, I'd like to thank you everyone for watching us. And if you think today we are going to talk about year discharge, if you think this is going to be beneficial for your friends and family, to like and share our session, Dr. Value is going to give a presentation for about 20 minutes. And after that, we are going to have Q&A session. If you have any questions that you'd like to know about your year, please stay with us, watch the presentations, and then you can ask questions. All right. Okay. Just a quick introduction about Dr. Value. So Dr. Value has been practicing as an ENT surgeon for almost 25 years. Was the HOD at the Hospital Tunku Jaffa, and currently Dr. Value is practicing in NSCMH Medical Center. Therefore, without any further ado, I'm gonna invite Dr. Value to start his presentation.
Thank you, Ms. Xiao. And hi, everyone. Nice to see you all in this page. I'm Dr. Value, and I am presently working in NSCMH Medical Center. I'm actually very pleased to share with you my experiences with year discharges. Now, after 20 odd years working in government, okay, and in private, I've come across a lot of patients who have year discharge, and many of them have failed to take care of the year, and they ended up with a lot of issues. So I'm going to do a short presentation, maybe about 15 minutes, and I'm going to leave it open to you all to ask me questions and how we can manage this problem better. So let me share with you some slides. Okay. All right. Okay, I hope you all can see the slides. Okay, good evening. Let's start with this. Okay, like I said, I'm Dr. VALUYEETHAM AMBU. Most people call me as Dr. Valu, and I'm the otorhinolaryngologist in NSCMH Medical Center now. And the topic that I'm talking to you about today is the discharging year. All right, and that's actually is a small hole, big issue. Now, the discharging year, okay, to many people may not be a major issue, but sometimes the problem could be quite deep-seated, and it could be eroding into the bone and causing a lot of problems. Now, I give you a graphic picture of the ear canal. If you look at this, the ear canal is so straight. This is just a graphic picture. This is not exactly what you see. A lot of times this canal can be tortuous, it can be narrow with the eardrum at the back. And the discharge could either appear from this external ear or it could come from this middle ear. Now, this is what we're going to talk about now. I'll take you a quick run on these discharges that come from this external ear. Okay, now that's the eardrum that you see on most occasions. All right, that's a normal eardrum. Now, when we say discharges, what are type of discharges that you can get? Sometimes you get pussy purulent discharge. This is mostly from the outer ear, and this is mostly because of infection in the outer ear, because of staphylococcus or streptococcus. You can have a hair follicle infection causing, a small large swelling then. Whereas if you get a mucoid discharge, almost always is from the middle ear. And only in the middle ear you have mucous glands. So if you get a mucoid discharge, it must be coming from the middle ear. And mucoid discharge, these are slimy mucus, like what you get in your nose. They are all mucoid, right? Then you come across with mucopurulent discharge, which are, of course, from middle ear with some infection. Now, what is worrying is this last two. Now, if you get a scanty, foul-smelling discharge, a lot of time, there's hardly any discharge. When you put a small cotton bud or something into the ear and you smell it, you get a real foul-smelling discharge. And now, this is where the problem is, the so-called small hole, the cholestoma that comes. We will talk about this as we go along. Now, you may get blood-stained discharge, and this blood-stained discharge could be just infection to start with, but what is worrying is it could even be malignancy, tumors, cancers eroding into the bone, and they cause blood-stained discharge. So let's look at simple infection. Very simple infection like this, diffuse otitis externa. A lot of people have this bad habit of putting cotton bud and keep on digging into the ear. It feels nice to dig into the ear. The itch goes away, but after some time we damage the skin. As we damage the skin, they get infected by the organism that's already in the ear canal, and they swell up and cause you severe pain. This kind of infection actually causes severe pain. But on the other hand, you can have something like this, one small localized swelling because of infection in the hair follicle. You get this anywhere in the skin. Any part of your skin, you can get a hair follicle infection, a furunclosis, right? Very localized. And this can be really painful because the skin in the ear is very closely attached to the cartilage, and therefore it can be quite painful. Now, our country, Malaysia, being a very hot country, we tend to sweat, and a lot of people tend to get this kind of fungal infection in the ear. Okay, two common fungus that we see here: Aspergillus niger, Candida. Aspergillus niger have got black spores. Okay, they have spores like this. The spores like this, all right, and a mycelium that's growing on your skin. Sometimes they can be very, very troublesome. They're itchy, they're painful when they have secondary infection, and they take a long time to get rid of them. Okay, just like when you leave a bread outside moist, and then after a few days you find mold growing on it. It's exactly the same thing. You have mold growing inside your ear skin. Okay, many people working in gardens, you get this fungus getting into the fingernails. You scratch your ear and you get this getting into the ear. We sweat a lot. Areas that we sweat and moist tend to develop this kind of fungus. People who have diabetes, immunocompromised can develop this fungus easily. Okay, now let's move on. Okay, look at chronic otitis. Why do we get chronic otitis externa? Chronic infection of the ear canal. And this can cause some of the discharges from the ear. Sometimes you have a very narrow canal, and this happens usually when you constantly use cotton buds to clean your ears and damage the ear skin. The skin gets thickened and it gets very narrow. But then, unfortunately, there are some people who are born with a narrow canal, right? And they have problems of cleaning the ear. Now, one must understand that the ear is a blind ending sac, and nature has created a natural cleaning mechanism. You don't really have to clean the ear. You don't have to do it. The ear cleans itself. Unless we have a problem. We are born with a narrow canal, or we have some growth in the ear like osteoma, some bony growth in the ear, or we have some very deep anterior recess, then the ear canal may need some assistance in cleaning. But majority of the time, the ear cleans itself. The trouble is, we start digging the ear using cotton buds and all kinds of instruments, picks, keys, and things like that, and we damage the skin. Once you damage the skin, then that ear loses its self-cleansing mechanism, and wax starts accumulating in the ear, infection starts coming in, and you start having a problem. Then there are some patients, unfortunate patients, who are immunocompromised, who are severely diabetic, and they also can develop chronic otitis externa. Okay, now as we go down, we did this study in Malaysia, the Ministry of Health. In 2006 to 2008, this study was done in Malaysia. We screened a huge population in Malaysia, and we were looking at ear infections and hearing loss. Okay, and we found that there was a significant proportion of hearing loss in the community in Malaysia. Almost 57% of them had a little bit of hearing loss. 43% of them had mild hearing loss, whereas 3.12% had profound hearing loss. If you look at it, 43% of them had mild hearing loss, whereas about 3% had profound hearing loss. And this is our statistics in Malaysia in the year, which was published at 2009 by Ministry of Health. Now let's look at that again, the figures that we collected. Among all these years that we found there's a perforation, chronic otitis media, we found that 85% of them, the year was dry. There is a perforation, but the year was dry. In 14%, that year was wet, discharging, pus, infection. So there was a persistent infection in 14.42%. The remaining were dry year, but they had a perforation, okay? Under WHO criteria, if you look at it, they say anything less, our perforation rate should be less than 4%. If you have anything more than 4%, actually significant burden, right? So anyway, ours was 14.42%. Within male and female, there's no big issues, not much difference, right? And within the people living in the cities and people living in the urban areas, not much different. There's no significant difference at all, okay? And if you look at it in various states that we analyze, Terengganu, Johor, Sabah, and all the way down, the lowest rate prevalence we found was in Melaka, Perlis, and Kuala Lumpur. The highest that we found was Terengganu, Johor, and Sabah. All right. Now, where are we in Negeri Sembilan? We are here. Okay. That's about 3.43%. Now, this was just a prevalence rate. Why? We have no idea. It's just a sampling population that we did, and we sampled more than 1 million population. It's a huge population, and these are the findings that we had. Now, looking at otitis media, infection of the middle ear, and we found that the prevalence rate was 5.09% in Malaysia among all the patients that we surveyed. Okay, so I'll just take you through a little bit of otitis media quickly. We have acute otitis media. Acute otitis media is very classical. It's very, very painful. Patient wakes up with severe pain in the ear, blocked, fever, and if you look into the ear, and the drum is so red and angry looking and bulging. We leave it like that. In a week or two, it ruptures and the pus comes out from the middle ear. All right. A lot of this is viral, and very commonly you see in children, which often resolves by itself, but most of the time they rupture and the discharge comes up. This is what happens. They rupture and the discharge comes out. In 90% of cases, the perforation that was caused by the rupture will spontaneously heal. You don't have to worry about that. 90% of the time, it will spontaneously heal, right? In a small percentage, 5% of the time, this may become chronic and may end up with chronic suppurative otitis media. Now, this may end up in a perforation like this, which remains forever, and that might need other surgical correction to close it, right? Now, let's look at it. When you have repeated infections, you may get scarring of the eardrum. You see the white patches that you see on this eardrum? These are tympanosclerotic patches. And this is the perforation that you see there. And because of chronic infection, you get scarring and stiffness of the drum. And very often when you try to repair this perforation, there's not enough blood flow in this area. So you have to remove all the chalk particles and regraft the whole drum. Okay. Now, the other thing that we commonly see in children and even in adults, especially when you travel a lot and you're stuck in aeroplanes and there's a pressure difference in the flight, you might end up in middle ear effusion. Why does this happen? This happens because the eustachian tube is blocked. The eustachian tube is in your nose, at the back of your nose, and a simple respiratory tract infection, URTI, upper respiratory tract infection, can cause the tube to be blocked, okay? And when it's blocked, you get negative pressure and you end up with the retracted tympanic membrane, pockets, and cholesteatomas if you just leave it like that. A chronic obstruction due to, a hypertrophic adenoids, or maybe even a tumor like a nasopharyngeal carcinoma, may lead to chronic retraction, and chronic retraction pockets can develop all this. Same thing with adhesive otitis media. Okay, let's look at it. If you see this cone of light is all fractured, and behind this eardrum, there's fluid. That's fluid. It doesn't cause any pain. It just causes some hearing loss, and the fluid is there. It gives you a block sensation and reduces your hearing. A lot of times this can be corrected if you know that it's just as a retracted tympanic membrane. We can make a nick here, let out the pus, and put a small tube and balance the pressure and settle the issue. Most of these will resolve spontaneously in children. You probably need not even do that. But if it's persistent for more than 3 months, you probably need to do that. Okay, so this is the eardrum. Again, if you look at it carefully, there's a bit of retraction and the cone of lights are broken away. There's negative pressure. Now, one must seriously consider looking into the nose. Because a lot of time when there's a block in the nose, there's some cancers growing at the back of the nose, especially in our country, Asian country, where among the Chinese, the Malays, there is a possibility of them developing nasopharyngeal carcinoma, and you can get this kind of appearance. All right. See this retraction pocket that you see, huge retraction pocket, and this chronic scarring of the eardrum. Okay. Okay. Again, you see the retraction pocket, all this because of negative pressure in the middle ear. Something in the nose, nasopharynx, is blocking the eustachian tube and causing negative pressure. All right, there you see that again. It's all blocked. It's all pockets that you see, pockets. And all this because something has been chronically blocking the eustachian tube, and the pressure in the middle ear is negative compared to the pressure in external ear. So nature has created the middle ear in such a way that the middle ear is connected to the nose using a eustachian tube. And that eustachian tube is exposed to the nose and atmospheric pressure. The ear outside here is also atmospheric pressure, so the pressure is equalized. When there's something blocking the nasopharynx, the nasopharyngeal area, a tumor or an infection or whatsoever, then you can end up with this kind of negative pressure. Now, this is an extreme form of negative pressure which has been there for a long, long time, and you found the whole tympanic membrane is already retracted and stuck to the middle ear. The handle of malleus is pulled backwards, everything has been stuck to the middle ear. This is what we call as adhesive otitis media. Okay, now we come to our issue of small hole and big problem. Now, this is the so-called small. The meatus itself is small, but as you look into the ear, you find the bulk of the eardrum here looks reasonably okay, and you see the small pocket at the attic. Now, this is the most dangerous perforation that you come across, because this practically eats into the bone, the surrounding bone, and it can extend into the brain, it can extend elsewhere, eating away all the bone as it keeps on expanding. What we see from outside is only this small thing. All right, if you're not careful, at the back, you could have a huge cavity. Okay, so middle ear disease, we have two types. One is the so-called tubotympanic, which is the safe perforation. All right, and this tubotympanic, you have a lot of discharges and all that, and you have this perforation in the eardrum, which could be as small as this, huge as this, or subtotal like this, which is usually doesn't give you a lot of problem. The worst case scenario, they give you a lot of discharge, they cause some hearing loss, all right? But when you get into this area of atticoantral, this small perforation that's up there in the attic, it eats into the bone and it can give you a lot of serious complications. This is one thing that one has to be aware of. And the discharge that comes from this is scanty. You hardly get a lot of discharge. So most people don't pay much attention. Unlike this could be pouring away with discharge. Whereas this, you might find just a little bit of discharge constantly inside the ear, a bit of foul smelling. Now, like I told you, the perforation could be like this, could be huge, involving the almost whole of the tympanic membrane, 80% of the tympanic membrane, all right? Or maybe even involving the whole tympanic membrane. But as long as it's in the safe part of the ear, this doesn't really cause so much a problem, and this can be repaired. It's not a big issue at all. Unless you have perforation up there, which is eating into the eardrum, then that is a small hole with the big problem that we talk about, and we call it as the unsafe ear. The unsafe ear, because this is one perforation that everyone must be aware. If you look at it, bulk of the eardrum looks perfectly normal. Bulk of the eardrum looks perfectly normal. If someone pays some attention and look right at the top of the attic and they see this, sometimes it's covered by wax. And most people think it's just wax and leave it alone, but actually behind that wax, you see this granulations, perforation, keratin, and that's happily eating into the bone at the back. And we don't realize it until it's too late. Now, this is what we call a cholestoma. Basically, it is skin in the wrong place. Skin growing into the middle ear. Skin growing into the bone. Basically, is skin in the wrong place. Now, how does it occur? There are a lot of theories on this. Let's not delve into all these theories. A huge lot of theories into this. Most commonly is due to negative pressure, and the squamous epithelium actually grows into the pocket of it. Okay? Now, if you look at it, the perforation is up here, very high. The bulk of the eardrum is normal. And because there's a negative pressure here, it forms a pouch. And this pouch gets bigger, bigger, much more bigger, and keep eating into the bone. And sometimes even get into the brain. Okay, now, the structures that are at risk, a lot of structures. If you just look above that is the brain, not very far away. You can get subdural abscess, extradural abscess. You can get intracranial abscess. You can get meningitis, whatnot. The infection can go backwards, involve the sigmoid sinus, and there could be blood clot in the sigmoid sinus, and that also itself can be problematic. And sometimes pus collection may come down into the neck. So there's a lot of structures nearby, very important structures. Another important structure that you see there is the facial nerve. This is the facial nerve. And sometimes this facial nerve can be involved and end up with paresis of the facial nerve or even paralysis. So you'll find your angle of the mouth drooping, you're unable to close your eyes, and it can be quite distressful. Now, what are the symptoms that you're going to come across? In this condition, the discharge is usually scanty. The classical feature of that is significantly foul smelling. It's got a typical characteristic foul smell, right? You may have deafness, you may not have deafness. In the early stages, you probably don't even have deafness, which is why people don't take this seriously. Most of the time, people come to see a doctor when they can't hear, when they lost the hearing. And by that time, there's significant damage already done. Okay. If you look into the ear, you might find some polyps, some granulations, and things like that. Now, I'll just give you some example of what you are going to see in the ear. The bulk of the drum is down here, is intact. Up there, which most people fail to see, even doctors sometimes fail to see this area up there, but they've been trained. Most of the doctors are trained to look for this. So when they take some trouble to look for this area, they will find this, and when they see this, they all can make a diagnosis of this cholestoma. Again, here you see the drum is intact, and at the back of the drum, you start seeing this keratin accumulation. Up there is where your small hole is. All right, see this drum, very nice looking drum down here. Endomelis is all fine. Up there is where your retraction, and you see this white keratin that's sneaking out from the pocket. If you actually go in and do a CT scan or something, you can see the huge cavity at the back. Okay. Okay, there we are there. Now, hang on for a while. Okay, we are there. So What we are concerned about is this perforation that you see here. This is what we call is cholestoma, which is happening in the attic. Now, if you are not careful with this will actually grow into the mastoid bone and even get into the brain. You certainly don't want to wait until the whole thing grows, become large enough to show up the ear. It comes out like a large polyp coming outside the ear like this. You want to pick it up while it is still inside there, but it's still inside the ear. You certainly don't want this to grow out and come out and show to yourself and tell, hey, I'm here, come look at me. No, that's the last thing that you want. And I hope we can get this thing sorted out early. Now, what can you do? Go and see your ENT doctor if you have a ear discharge. Most of the time, they will examine you under microscope. It's a very important thing to do, all right? They might take some cultures and treat you. They do some hearing tests for you, all right? But what is more important is a CT scan. This will show how much of the bone is eroded, where is the lesion, and where it is extending and what can be done for it. Basically, we want to know how much of the neighboring anatomy has been involved, all right? Now, how dangerous is it? Very simple. Based on its position, based where the lesion happens, it can go up into the brain, it can go back involving the sigmoid sinus, it can come all the way down, collecting abscess in the zygoma, mesocytilis and all that, causing mastoiditis. It can cause severe labyrinthitis and severe giddiness. It can cause facial paralysis and putrescitis. So actually, these are all complications that happen outside the cranium. But you can also go into the cranium and cause abscess, intracranial abscess and things like that. Now, look at this young gentleman and you see this collection that you see here. And this is actually a huge collection that's coming up from the cholestoma. This is a huge collection. You see the bone, the way it's eroded. This is a simple plain X-ray. Now, many years ago, we used to do a lot of plain X-rays, which we don't do now. We would prefer to do a CT scan to see something better. We can see such a huge erosion and collection here, plus the bone has been all eaten away here. It's been eaten away here. And when we look inside, we can see collection of pus, which is an extradural abscess. See collection of pus here, which is actually pressing into the brain. So when we drain this and let out the pus, and and we clear all the infection that is down there, this can be resolved quite easily. It's not a problem, but we don't have to wait until we get to this stage. Now, I mean, this is kind of an extreme that we are seeing. It's not that we don't see this anymore, but we do see on and off. But this is something that we don't want to have in our country. Now, what we do? Follow up. Whenever we find this, of course, the treatment is quite straightforward. We clear up, open up the whole mastoid cavity, remove everything there, remove all the cholestestomas, all right? And we keep following them up lifelong to make sure it doesn't recur. It doesn't recur. That's what's more important, so that it doesn't recur. Okay. All right. So as for our presentation of this small hole, this is the thing that I would like to highlight to everyone regarding the problems of cholestoma. Ear discharge is there. A lot of people get ear discharge. It could be a simple infection in the external canal. No big problem, can be easily treated. But this kind of ear discharge that comes from the inner ear, not inner ear, sorry, it's from the middle ear, from a perforation in the attic, could be quite life-threatening. Thank you. Thank you for your attention. And I will be more than happy to take any questions if you have on this.
Okay, thank you, Dr. Valu, for your sharing just now. So, Doctor, so which means you said our human body, they're going to clear the discharge by themselves. Basically, we don't have to do anything.
Exactly. The human body, nature has created the skin such that whatever debris that collects in the ear naturally is cleared, unless we mess around with it. We mess around with it by putting a cotton bud, digging the ear, damaging the natural mechanism. No,
Okay.
you really don't have to do anything to the ear. Even if this dries up, okay, you don't have to do anything with it. But people have this habit of putting cotton buds and cotton and picking the ear and things like that. And that's what causes damage to the skin. And when that skin is damaged, that's when wax and debris accumulates.
I see. Okay. I mean, doctor, what about this? You know, it's very popular in the saloon. It's called the ear candle.
Okay.
I mean, what is your opinion? I mean, different people have different opinion about this.
To me, I think it doesn't really help. It doesn't really help the ear. Okay. You can see a warm sensation in the ear and the surrounding area. A good feeling, that's about it. Doesn't to the ear. It practically doesn't into the ear. Yes, if you're not careful, the wax might drop into the ear, might damage your eardrum.
Okay.
It's hot, remember? But on the other hand, it does nothing. It gives a warm feeling around the ear, and that's about it.
Okay, understood. So if you just want to have that sensation, by all means, but however, this is just our own personal opinion. Okay. So doctor, I've got some questions here. I heard ear discharge is one of the symptoms for ear cancer. Is it true?
Yes, I did put up a slide earlier. If you have ear cancer, the discharge is usually bloody, sometimes blood stained. Yes, ear discharge could be one of the symptoms of ear cancer, right? And especially more so when it's bloody. And cancers come up in the initial stages, they're not painful. They're not painful.
Not painful. Okay.
They're not painful, which is what misleads most people. Infections can be really painful. You could have a fruncle in the ear, very painful. Okay, and fruncle is causing is actually a cancer. It's not. It's just a simple infection. But a lot of cancers don't cause so much of pain.
Okay, right. So cancer, one of the symptoms is blood staining discharge.
Blood staining discharge, yes.
And it's not always painful, or it can be not painful at all. You say
painful until towards the late stages.
Okay, all right.
Okay.
Noted about that. So I've got another question, doctor. Here is from Miss Zinatu Basira. Doctor, kalau telinga selalu gatal, what is the reason?
Okay, when gatal we mean you are talking about itchiness, lah, right? Right. A lot of time there are two things involved here. One, the person could be having allergies. When you have rhinitis, you have running nose, sneezing, itchiness in the nose. You could have itchiness in the throat, and also itchiness in the eyes, itchiness in the ears. And itchiness, you tend to use cotton bud and keep on digging. The more you dig, the more itchiness you develop. All right. The skin is very sensitive. The more you use the cotton bud, yeah, it feels good, but the more you do that, the itchiness gets persistent. So one part of it is allergy. It could be allergic, simple allergy. Now, the other part could be a fungal infection. I showed you a picture of the fungus just now. Our country is hot. It's a tropical country. We sweat a lot. And when we sweat in the ear is always moist. Any area which is moist and doesn't run, you can develop fungal infection. And that can cause severe itchiness. So those two things. Then there's again some small group of population who develop psoriasis.
Okay, psoriasis.
They too can have itchiness in the ear, and of course it can be very troublesome. Dry skin, very troublesome, and you're very tempted to use a cotton bud to keep on scraping it, and and make the symptoms worse.
Right. Seems like cotton bud is the root cause of, well, not root cause. It causes a lot of problem.
It's a no-no in the ear.
It's a no-no in the ear. Okay. So as you mentioned just now, it could be like 3 reasons, like allergic, or could be fungal infections, or it could be one of the common skin conditions which we call
Yes.
psoriasis. Okay, I
Yes.
hope it answers your questions. Let me have a quick look. All right. Okay, so the questions here, how often shall we clean the earwax?
Okay.
We leave it to the
I
nature.
did mention to you just now,
Yeah,
the ear cleans itself. We
the ear cleans itself.
don't do anything at all. It cleans itself. Now,
Okay.
unless we are born with a very tortuous ear canal or a deep anterior recess, then we probably need to clean it. And the best person who will be able to do it is either an ENT doctor or your general practitioner who has a otoscope, lights, and instruments. He'll be able to suck it out. Right now, today's market, we have a lot of some devices are there. You can actually put it on the ear and suck out the earwax. There's some devices in the market. And also there's some solutions and medicine that you can apply to dissolve this wax and come out. This is available. If you would ask me, I would say don't do it unless you know what really is happening in the ear first.
Okay, get it checked first before you do it yourself.
Before doing that.
Okay, right. Question, sir, doctor. Is there a difference between cholesteatoma and cholesterogranuloma?
Okay, cholesterol granuloma is accumulation of cholesterol underneath the drug. Yes, that is an obvious difference there. Cholesterol granuloma is just cholesterol, accumulation of cholesterol granulation underneath. Usually it doesn't cause much problem, but yes, if a lot of it accumulates, you can have some problem. But cholesteatoma is slightly different. It's keratin. It's basically keratin. Your skin produces keratin. Now, if you understand the skin is on the surface, the dead cells come out and they fall off. They naturally fall off. They fall off. They don't accumulate. But if you invert the skin the other way around, the keratin will accumulate in there. And it starts growing in size, like a big sack inside that. Okay? And when that starts growing and growing, it's going to cause expansile destruction of the neighboring structures, whatever is that. It's going to start eating into all that and keep going down there. So of course, that's much more dangerous than the cholesterogranuloma. Sometimes you do see cholesterogranuloma. It is there for a long time, not causing any problems, right? It could be middle ear, could be in the pitcher's bone and things like that.
Okay. All right. Hope they answer your questions. All right. So I've got Shantini asked, does tonsillitis link to the ear infection?
Of course it does. Tonsillitis and any infection in the nasopharynx. See, the tonsils is part of a lymphatic ring. We call it Vail-Days ring. All right. This ring consists of the tonsil, the lingual tonsil, and the adenoids. Now, the adenoids are in the nasopharynx, and the eustachian tube is just at the back there. So any infection here can cause chronic discharge in the nasopharynx, obstruction of this tube. And when this tube is obstructed, then you can get blockages in the ear, negative pressure. You can get effusions, tympanic membrane can get retracted. You can get otitis media and all that. Okay.
Yeah. So it's linked. Okay. So we have Dr. Horn here. Dr. Horn asked, sometimes I feel giddiness. I was told it is due to the balancing mechanism in the eyes. Can you explain this, please?
Again, can I get?
All right. Sometimes I feel giddy. I was told it is due to the balancing mechanism in the eyes. Can you please explain? Yeah.
Okay, now if you feel giddy, there are many reasons for you to feel giddy. To be stable, there are a few things. One is your eyes, the other is your ear, and then the rest of your receptors that come from your body, right from your foot all the way up. Right from your foot, ankle, knee, hip, neck, and all that, right? All these systems, the ears, eyes, and this proprioceptor system, they all interact and the brain gets an idea of your position in space, right? When one of these systems are not functioning adequately, then you tend to feel giddy.
Okay.
The ear, it could be the eyes, it could be this whole system that comes from your foot, okay? Most commonly, infections in the ear, if you have infections involving the labyrinth, yes, it can cause very severe giddiness. Ear are usually they spin a lot, they rotate, they push you down, gives you a falling sensation and things like that.
Okay. So it depends on, because several organs that may cause giddiness, so
Yeah.
we need to know which one it is.
The
Yeah.
whole combination of the eyes, ears, and the proprioceptors.
All right. We have Pavitra here. Any chance to get ear polyps? Actually, just now, doctor, you did show the ear polyps. It just reminds me of somewhere else, like the pulse, the polyps. I mean, like, how, any chance, I'm guessing possibly, how do we get this? Or how can we prevent this?
Okay, now when we say ear polyps, there are two types of ear polyps. That comes from the external ear. That means outside the drum, tympanic membrane. Skin from the external ear, because this is usually because of chronic infection.
Okay.
You have impacted wax that has not been cleared and all that, they get infected, and then you can get a polyposis coming out from the external ear. A lot of time this is not an issue. You just remove this, the story ends there. An issue at all. Now the polyp that I showed you was coming from the middle ear. We have a cholestoma and you have granulation tissues, and this has been neglected, and this polyp grows and grows and grows and grows, and one day shows itself out there to you. Hey, I'm here, come have a look at me.
It's from inside to outside.
Yeah. And that's something that we really don't want. That's also because of infection, cholestoma and infection and all that, but that's coming from middle ear.
Inside.
One that comes from external ear, most of the time is not an issue. We can quite easily remove it, and the story can be ended there itself. No issues. The middle ear, of course, you need major surgeries and all that. You have to preserve structures, open up the whole ear and go in and see what's happening.
Okay. All right. Right. Oh, so I think that Tohan said, sorry, he meant the ear, not the eye just now. But I think just now, doctor, you did answer about if there's infections of the, what you call lady ring, right? How do you pronounce the word again?
Infection of the ear, otitis externa.
Yeah. So I mean, because I think what Dato asked was he feel giddy. It is told because of the due to the balancing mechanism in the ear. I guess like a lot of patients in Chinese we say because of the water is not balanced. The water is not balanced. Actually, we would like to know, does that cause giddiness, and how come the water become not balanced already?
All right, let me go a bit more specific. Let's forget the peripheral system. Let's forget the proprioceptive. Forget the eyes. Let's say all these are normal. Let's say the eyes vision is normal, and your proprioceptors all are normal. Not worried about that. Let's focus only on the inner ear, your balance system, the so-called balance system. This balance system is controlled by 3 canals, right? And there are fluids in these 3 canals which are moving. This fluid is moves. You turn your head to the left or to the right, or you go up or down. You know, this canals plus your saccule and your vestibule. Okay, it helps. The saccule vestibule helps in your linear movement, and the canals help you in the rotatory movements.
Okay, I understand.
Both side canals move equally. All right. When you turn your head and both canals move equally, there's issues. No issues. The right moves this way and the left move the other way. There's no issues. When this is affected, in some people, very commonly, what happens is we have a condition called BPPV, benign paroxysmal positional vertigo. There's some otolith. These otoliths are nothing but just calcified deposits that drops off from the otoliths. All right, they fall into this canal. Why they happen, we don't know. A lot of times it's just degenerative changes, aging. Sometimes could be infection. Sometimes you have a head injury and things like that. This drop in one canal on one side. So when you turn your head left or right, or you get up from lying down position, okay, or you try to lie down, these canals move. Now, one set fluid is moving faster than the other.
Okay.
We'll talk about imbalance. Faster than the other. And you know, so when this moves faster, you feel the spinning sensation until the fluid stops. The moment the fluid stops, this giddy sensation goes away. This is seen in a lot of people. right? Especially when they're trying to lie down, when they're trying to get up, when trying to turn left, turn to the right. It's a very short thing that happens for a few seconds, maybe a minute or two, and that's about it. The moment you stop, and it stops. Okay, so serious about this, but it does happen. But of course, you must, when you have giddiness like this, you have to assess the patient as a whole. You also have to see what's happening with the brain. Is there any other issues with the brain? Some it could be issues with TIA. TIA means like early strokes and things like that.
Okay.
So you have to assess the patient as a whole, not just look at one small thing.
Okay, understood. I think Dr. you explained very clearly. Now I can understand like why people experience giddiness, because of the mechanism that they're still moving because of unbalance there. Okay, right. So I have Yasin here. I have some stiff feeling or blocking feel at the ear. So she feel blocked. Is it the symptoms of ear infection?
Okay, when you have a block sensation, all right, either you're blocked the external ear, which is most commonly wax. Okay, the external ear, most commonly wax. Let's say you don't have wax and you have this block sensation, chances are you have some ear infection in the middle ear. Okay, so you have negative pressure and it gives you a block sensation. Sometimes when you have tonsillitis, adenoiditis, or sinusitis, that is the eustachian tube, there's some swelling in that area, and you get a negative pressure. So fluid tend to accumulate in the middle ear, and it's called middle ear effusion. I'm sure you would experience this when you've taken a flight, gone somewhere overseas, and as the plane tend to descend down, a lot of people get the severe pain in the ear. Especially when the aircraft is not well pressurized. Aircraft is well pressurized, pressure is equalized slowly and gently, you don't get this problem. But some people do, all right? This, what happens is, because the tube is locked, eustachian tube is locked, and so you get negative pressure in the middle ear and you get this block sensation. So even if URTI, a simple upper respiratory infection, a simple sinusitis, tonsillitis, you have swelling around the eustachian tube and cause block ears.
Okay, right. I hope it answers you, Yasin, because I do experience that myself as well, especially when I have sinus. I do experience that as well. And now we have Jaya Lakshmi. Hi, doctor. What are the side effects of using earphones to listen to music? The range of decibel ears are designed to hear safely.
Okay, earphones. Very interesting question and a very good question. Today, our young generations are forever on the earphones. All right. Earphones, when you put at very high volume levels, are damaging to the ear, especially when you use it for long periods of time. Earphones are designed, nowadays, you have a lot of earphones, they have an automatic clipping level. The volume is clipped at a certain level. Okay. Unless you voluntarily increase it, so there are certain safe levels. If you buy good quality earphones, the volume, you plug it in, the volumes are already clipped. It doesn't exceed certain levels, right? But if you're not using such earphones, you have to be careful, because if you expose your ear to loud noise, invariably over a period of time, you can have hearing damage. You can have hearing loss, and especially noise-induced hearing loss can be very problematic in the future. It doesn't recover, Initially, it may recover. The first few times it may recover. After a while, it may end up with permanent threshold damage where it doesn't recover.
I see. Okay.
Be careful about the volume that they use.
Okay, because I think she actually asked us, from the same person, she said, has the percentage of hearing loss in people risen because of earphone usage?
Come again, what's the?
Has the percentage of hearing loss in people risen because of the earphone usage?
Actually, I can't give you exact number because I haven't done a study or anything like that. But if normally if you use a earphone or if you're exposed to any loud noise, 80 decibel and above for a period of 8 hours, you will develop hearing loss, noise-induced hearing loss. All right, that's 80 decibel. But if you're using really loud, that means 100 decibels or 110 decibels, You don't need to close for 8 hours. Even a few hours, like 2-3 hours, can cause hearing loss.
Okay, wow. Is it permanent?
Yeah, it does. It does. Okay,
Permanent, wow.
I give you an example. The loudness. To give you loudness, in most, like say, my air condition in this room is 40 decibel. In your room, it is already about 40 decibel. And imagine then your earphone at 80 and 100 and 120, the louder the noise that you hear, the higher the chance for hearing loss, and the due shorter. You don't have to be 8 hours. Shorter, So that's how it is. I can't give you a definite figure, what's the percentage with that. I don't have that. But the fact remains, the louder you hear, higher is the chance of you losing your hearing or developing noise-induced hearing loss.
Okay, all right. So today, doctor, I think now it's 9:20. We have already spoken for about almost an hour. So I'm gonna ask the last questions. So, Dr. Valu, does swimming increase the chances of getting ear infection?
Okay, it's a good question. I get this question from a lot of my parents, children's parents who come to see me. It really doesn't, all right? In our country, in Malaysia, it doesn't. Sometimes the amount of chlorine content in the swimming pool is quite high. These chemicals that irritate the ear canal, so it can cause infection. Now, if you have a problem, you have a perforation, that means you got a perforation in the eardrum, and yes, that can cause an infection. If water gets into it, especially when you start diving into the pool, water gets into the ear, and water gets into the ear. If you have a chronic suppurative otitis media, you can have episodes of infection. All right. Now, when you swim in cold countries, very cold waters, they tend to have osteomas, bony outgrowths in the ear canal. Okay, that happens in cold countries. People who swim osteomas. We don't see much of that in Malaysia. We don't see that in Malaysia. All right. Infection, yes. If you have a perforation, please use a ear plug, use a silicone cap, protect the ear before you go for swimming.
Okay.
Right. If you don't have a perforation, if you have a normal canal and intact drum, usually it's not a problem.
Okay. All right. So which means commonly in Malaysia, no, unless you already have the existing problem.
Problem with the ear. Keep in mind, if you have a perforation, please have the ear. Don't simply go swimming when you have a perforation.
Perforation, yeah. So I guess the kids has no reason to tell the parents, I don't want to go swimming class anymore, because it actually doesn't increase the risk of getting ear infection.
Even if you have a perforation, you have earplugs that you can use to protect. We have silicone caps to water from getting into the ear. The reason why you should be swimming.
Yeah, you have no excuse at all. You can get earplugs even you have ear problems. So, okay. So I guess that's the end of the session for today, Dr. Valu. Again, thank you again for spending 1 hour, almost 1 hour to answer all these questions. And let me see. Oh, sorry, I want more. Just one last question. Rupture eardrum. The hole, wow, so many. The hole, will it heal by itself?
Okay, ruptured eardrum has got many reasons why they rupture. Okay, just talk about traumatic rupture. Traumatic means you accidentally poke your ear. If you're digging, they damage the eardrum. Cleaning ear and somebody knock on your hand, you rupture the eardrum. If an accident, motorbike accident, or somebody slap you on a ear and rupture the eardrum. Most of these traumatic ruptures, I'm not saying all, but most of them will heal by itself. You don't need to do any kind of surgery. You don't do any kind of surgery. Traumatic ruptures will heal them. There will be some that doesn't heal, which might require some repair. That's a different story. Now, if you rupture because of infection, and if it persists more than 6 weeks, all right, then what happens is the edges of the perforation become epithelialized, and they don't heal after that. Then you may need to do some kind of surgery to patch up that perforation. Right? So traumatic rupture, 90% of them I find they heal. They really don't do anything. Just keep the ear dry, most of them heal. Those that doesn't heal after 6 weeks, maybe you want to do some kind of surgery to patch them up.
Okay.
Yeah. But
Okay.
infections also, we can wait, give it some time, 6 weeks, 2 months. If it doesn't heal, then you need to do some kind of surgery.
Okay. All right. I hope we answer your question, Miss Sang. Okay. All right. Okay. Thank you, Dr. Velu, for the session. So let's say bye-bye to our audience together.
Okay. Bye-bye.
Okay. Bye. Thank you, Doctor.
Thank you very much.
Thank you.
Okay.